Next, we are moving to the plenary lecture. The topic is Antithrombotic Strategies after Percutaneous Coronary Intervention. And the speaker is none other than Professor Asfa Saman, our guest speaker. And yesterday, actually, we discussed in brief regarding this topic, but today we are going to hear things in detail. And to chair the session, I would like to invite Senior Consultant Cardiologist Dr. J. Bulumulla and Consultant Cardiologist Dr. Sunet Karunaratna. Over to you, sir and madam.
Okay, thank you. So yesterday's talk was about updates in acute coronary syndrome. So today I'm going to talk specifically about antithrombotic strategies after percutaneous coronary intervention. So the guidelines have changed somewhat, and I think they've added a lot more clarity about what we should do. So I'm going to talk about chronic coronary syndrome and acute coronary syndrome. In chronic coronary syndrome, the PCI 212 inhibitors now are given once angiography is performed, and the decision is made to proceed to PCI. So whereas before, if patients were coming for a query proceed, we didn't know their anatomy, we would load with clopidogrel. Now, the advice is that you only give a P2Y12 inhibitor, typically clopidogrel for chronic coronary syndrome, only once the decision is made to proceed to PCI. And the reason for that is that when we look at review of all of the trials that have been done in this space, there's very few that have been done pre and post. There's one. If you give the P2Y12 before and you don't proceed, then there you increase the risk of bleeding. So now only when you know the anatomy do you give the P2Y12, and therefore it can be given in the cath lab. And for the chronic coronary syndrome, stable cases, clopidogrel is sufficient. So there is a lot of clarity in that area. For non-ST elevation myocardial infarction, and I talked about this yesterday, if invasive coronary angiography is planned within 24 hours, in Europe, we've changed from ticagrelor to prasugrel. Once again, you only give it once the decision has been made to proceed to PCI. And for ST elevation myocardial infarction, we give prasugrel just before. So what has led to this change? So what I've done is I've reviewed the history of percutaneous coronary intervention, because I think that will help you to understand why these changes have been made, and I think the changes have been simplified. So if you look at when we started off with angioplasty in the days of Groentzig, the goal was to have an open artery. And it was obviously to avoid coronary artery bypass graft surgery. But the problems that we had with the balloons that we had at that time, 70s, 80s, and 90s, was that you had around 20% of vessels that would recoil and lead to vessel closure. So approximately 10 to 15% of patients would go straight from the catheter lab in the 90s up to theatre for coronary artery surgical revascularization. So in order to prevent recoil and vessel closure, we had bare metal stents came along, and they were great. So they reduced the emergency coronary artery bypass graft surgery from around 15% to around 2%. But of course, the problem with bare metal stents was in-stent restenosis. So then technology improved to develop drug-eluting stents to prevent in-stent restenosis. But the problem in 2007 was that presentation in the ESC by Kemenzind, which showed that you had an excess of stent thrombosis, and therefore at that time we extended dual antiplatelet therapy, and we were very, very switched on about stent thrombosis, and the advice was that you gave dual antiplatelet therapy before the procedure and you continued it for 12 months. And the reason for that was to prevent stent thrombosis, which was a function of the first generation drug-eluting stents. There has been an evolution of PCI pharmacotherapy in tandem with the evolution of the drug-eluting stents. So if you want to reduce ischemic risk, you would ideally want to extend dual antiplatelet therapy and maybe even add a third agent, an anticoagulant, and I'll talk about this. And in order to prevent ischemic risk, you can now extend up to 3 years with 60 milligrams BD of ticagrelor based on the Pegasus study. But the yin and yang of reducing ischemic risk is that you increase bleeding risk if you extend dual antiplatelet therapy or add anticoagulants. So in order to reduce bleeding risk, you have now the option of reducing dual antiplatelet therapy for a duration of 1 month. And that stent technology, which I'll talk about, has allowed you to do that. The device risk has now been minimized. So from the era of drug-eluting stents giving rise to stent thrombosis, we now have stents with thinner struts. We now have stents with no polymer, and of course all of the stents that have polymer and now have biocompatible polymer. And these changes, this evolution, has led to a reduction in the incidence of stent thrombosis to around less than 1% and around the figure of 0.5%. And of course, we're now seeing an evolution and increase in use of drug-coated balloons, which of course leaves no metal behind, and therefore the risk of stent thrombosis is minimized or indeed is zero. So technological evolution has allowed us to minimize dual antiplatelet therapy. Now, in terms of dual antiplatelet therapy, whilst this was not a study in a high bleeding risk patient, the seminal study in this field is the STOP-DAT2. It was in a Japanese population, but the main message of this study was that it was safe to give 4 weeks of dual antiplatelet therapies. So this was a study of over 3,000 patients where the patients were randomized to aspirin and typically clopidogrel for 4 weeks. And then after 4 weeks, the aspirin was stopped and only clopidogrel was maintained. And the follow-up was to 5 years. And this was compared to standard management with 12 months of aspirin and clopidogrel. And after 12 months, only clopidogrel was stopped. The primary analysis for non-inferiority at 1 year showed that there was no difference between the two groups. Indeed, the group in which aspirin was stopped after 4 weeks had reduced risk of bleeding. But forget about that. What was the take-home message of this study? The take-home message of this study was for the first time with the third-generation drug-eluting stents that 4 weeks of DAPT was safe. And now, of course, you heard me say this yesterday, what determines duration of dual antiplatelet therapy in your patient? It's bleeding risk. And it is the bleeding risk that has led to innovation in our stents and in our pharmacology. So this is a really important slide. So on the y-axis, you have patients, and on the x-axis here, you have the number of high bleeding risk criteria ranging from 0 to 3. The take-home message is this, is that as you get an increase in ARC-HBR criteria, you get an increase not only in bleeding in red, but also in device-orientated clinical events. So not only do you get increased bleeding as you get more ARC-HBR criteria, you get more device-orientated clinical events. And typically this is target vessel failure, stent thrombosis, target lesion revascularization. So high bleeding risk is associated with high ischemic risk also. And this is what has driven the change to the antiplatelet therapy with these patients. The STOP-DAT was a seminal trial, not in HBR patients. What about the HBR trials? And what I've tried to do is to minimize this and to give it some rationality so that you can understand. There are many, many trials, and I'm not going to go through all of these trials, but I want you to understand that the trials have taken part in essentially, there are 2 parts. One is where you compared stent A with stent B. Okay, so typically it was a bare metal stent against a drug-eluting stent or a drug-eluting stent versus a drug-eluting stent. The second class of trials was where you had the same stent, but you had a shorter, typically 4 weeks of dual antiplatelet therapy compared to a standard 12 months. Let me talk to you about the stent A versus stent B. And what I've done, I've highlighted those studies that were randomized, of which there were 4. Okay, the Zeus HBR was the first such study that compared the Zoterolimus Endeavor versus a bare metal stent. There was the Leaders Free, which compared the Biofreedom with this equivalent Gazelle bare metal stent. And then there was the Senior study, which had the Synergy versus the Omega and the Rebel bare metal stent. But the Synergy had up to 6 months of dual antiplatelet therapy. The modern stent trial was the one that I was involved in, which was the Onyx 1, which compared the Resolute Onyx drug-eluting stent, which the Biofreedom drug-coated stent. And this was the latest comparing two drug-eluting stents and found non-inferiority in terms of bleeding and stent thrombosis. If you look at the short versus standard DAPT trials, there's only one that was randomized, which was the Master DAPT, which compared the Ultimaster stent with a shortened 4-week DAPT versus a standard 12-month DAPT. And once again, it showed non-inferiority. So what all of these studies tell us is that in your high bleeding risk patients, 4 weeks of dual antiplatelet therapy is safe. So if it's safe in your high bleeding risk patients, it follows that it's going to be safe in your non-high bleeding risk patients. So the message is that with the modern stents that we now have, technological advancements have led to safety of these products with just 4 weeks of dual antiplatelet therapy when it comes to safety as measured by stent thrombosis. So this is what has driven this change, and you've seen this change before. So in stable coronary artery disease, chronic coronary syndrome as it's now called, you now base your duration of dual antiplatelet therapy based on high bleeding risk. Okay, you assess these patients for high bleeding risk. If the bleeding risk is high, you can have aspirin and clopidogrel for either 1 month or 3 months. Okay, big change. 1 month or 3 months, and remember, it's the drug-eluting stent technology that has driven this. If the bleeding risk is low, no high bleeding risk, and what I see in Sri Lanka is that the patients undergoing PCI are younger, so they may have no bleeding risk. You can now do 6 months of dual antiplatelet therapy as standard. If you think there is high ischemic risk, you may extend that for a further 6 months. What about anticoagulants? Well, we all know about thrombin. Thrombin is the conductor of the coagulation cascade. Not only does it activate platelets, it makes fibrinogen, creates fibrin strands from fibrinogen. So thrombin is central. And we know that comorbidities increase atherothrombotic risk, such that renal impairment, diabetes, heart failure, and polyvascular disease, as we've heard from earlier studies, increase your risk. So who are the patients with stable angina in whom you may consider DAPT or adding an anticoagulant beyond 6 months and up to 12 months? Well, these are typically the sort of patients that you would consider extending dual antiplatelet therapy. And of these, particularly those with polyvascular disease, so atherothrombosis in different vascular beds, carotids, peripheral, and coronaries. Anticoagulants, you know about the COMPASS study. So when would you use low-dose rivaroxaban? Typically in patients with severe peripheral arterial disease or polyvascular disease, because these are patients at the highest ischemic risk. So aspirin and clopidogrel is safe for most, but in your highest risk of ischemic heart disease and ischemic disease, those with polyvascular disease, you can consider adding in 2.5 milligrams BD of rivaroxaban. Okay, so it's simple. Decide for your stable patients, high bleeding risk. If yes, you can reduce DAPT to 1 month or 3 months. If there's no bleeding risk, majority is 6 months. If there is polyvascular disease, diabetes, i.e. increased ischemic risk, you may consider adding in low-dose rivaroxaban to that patient population. And these are the ESC guidelines that you should consider. It should be considered low-dose rivaroxaban in those with high ischemic risk and in those with moderately increased risk of ischemic events. And here's the definition of what high risk and is. So diabetes mellitus, recurrent MI, peripheral arterial disease, chronic kidney disease, and multivessel disease can be added to that. So very, very clear guidelines about which patients you should consider adding in low-dose rivaroxaban. So the take-home message for chronic coronary syndrome, stable angina, no need to preload with P2Y12 before the procedure. You can do that in the cath lab. Duration is now based on bleeding risk. Maximum duration for the majority is 6 months, and low-dose anticoagulant use based on future ischemic risk. What about acute coronary syndromes? There are now 3 options. So the majority is 12 months. And once again, it's the same thing that is driving this. It's stent technology that has driven the changes to this. High bleeding risk, Onyx 1 study, Leaders 3 study tell us that 1 month is safe. Okay, so we had questions yesterday about surgery, patients going for surgery. Ideally, you want DAPT for 1 month. If it's emergency surgery, of course, the patient has to go, and you can cover with Cangrelor. High ischemic risk, now the advice is that you can continue therapy with low-dose ticagrelor, 60 milligrams BD, for up to 3 years. Very, very simple, and this is the message. So this is the more complex chart that the ESC gives. Once again, division is based on bleeding risk. Remember this, when you decide on duration, it's based on bleeding risk. Very high, as I said, you can minimize it to 1 month of DAPT followed by clopidogrel. If the bleeding risk is high, use your app, ARC-HBR app. You can extend aspirin and clopidogrel to 3 months, followed by aspirin only or clopidogrel only, depending on bleeding risk. If the bleeding risk is low, you now have the option of aspirin and ticagrelor for 3 months, followed by ticagrelor only. And the next generation of trials now is looking at stopping aspirin, but continuing with a P2Y12 inhibitor. And this is where the majority of your patients will be. Okay, after acute coronary syndrome, 12 months of dual antiplatelet therapy, and you have the option of all 3 of the P2Y12s. And in a subset of your patients with high ischemic risk, these might be patients who have had a second acute coronary syndrome, you can now have the option of increasing therapy to up to 3 years. And that can be with low-dose rivaroxaban and aspirin or low-dose ticagrelor on aspirin. And those are the 2 commonest regimes that we use. So once again, you base the initial therapy on bleeding risk, you can extend based on ischemic risk. So what's the take-home message for acute coronary syndrome? The big change, and I have doubts about the study that led to this, is that the ESC has now switched to recommending prasugrel as the first choice P2Y12 and clopidogrel, obviously, if it's high or very high risk. The default is 12 months of dual antiplatelet therapy. It can be shortened to 1 month based on bleeding risk. The modern stents are safe. Or it can be extended to 3 years based on ischemic risk based on the Pegasus trial. If you want to extend to 3 years, you can have dual strategy, i.e. aspirin and rivaroxaban low dose, or you can have aspirin with low dose 60 milligrams BD of ticagrelor. There are now studies currently ongoing about looking at stopping aspirin and just continuing with ticagrelor. And in global leaders, it was safe to stop aspirin after 3 months, and that is what has led to the change in the ESC guidelines, that if you want to, you can stop aspirin after 3 months and just continue ticagrelor. But there's quite a few studies in this area ongoing at the moment looking at stopping aspirin because of the association of GI bleeding with aspirin. It was mentioned yesterday, and I'll say it again, whenever you give a DAPT or rivaroxaban, you must cover with a proton pump inhibitor. What about patients with an indication for oral anticoagulation? Typically, these are patients who have come in with atrial fibrillation, or they've developed atrial fibrillation during the admission, and you need to start an oral anticoagulant. So once again, this is the recurrent theme. Assess your bleeding risk in your patient, okay? If it's very high on the right, then it's dual therapy with clopidogrel and an oral anticoagulant. The recommendation for AFib now is that you use a novel or direct oral anticoagulant, and it's dual therapy for 12 months, after which time you stop the clopidogrel. If the bleeding risk is moderate, not very high, you can give triple therapy for a month, after which you can either stop one of aspirin or clopidogrel, and then at 12 months, you stop the antiplatelet agent, and it's just oral anticoagulant. If the bleeding risk is low, you can continue triple therapy for up to 6 months, then you stop one antiplatelet, and then you continue for 6 months, but after 12 months, the standard therapy is just the oral anticoagulant. Okay? No need for an antiplatelet after 12 months. So the message is consistent. Base your antiplatelet therapy on bleeding risk at the time that you see the patient. Very high, moderate high, or low bleeding risk, and that is what determines antiplatelet therapy. This is the app that I talked about yesterday, able to download, and it's very simple, and it allows you to assess bleeding risk in the patient in front of you using phenotypic data. And this is what you get. You get a trade-off in the blue line, or you get a mortality-weighted trade-off in the red line, and that will tell you about the risk of ischemic risk, MI or stent thrombosis, or bleeding risk, I, based on BARC 3 or 5 bleeding criteria. Based on this result, you can then determine your dual antiplatelet therapy regime. So in summary, what has driven the change in recommendation about duration of dual antiplatelet therapy is stent technology. What I hope I've shown you is that from the start of percutaneous coronary angioplasty it took up in the late 70s, but really took up in the 90s, from doing balloon-only angioplasty, the evolution of bare metal stents to the first generation stents to now we have the third generation thin strut drug-eluting stents. This technology has allowed us to show that the modern stents are now endothelialized after around 4 weeks. And these were animal studies and OCT studies in animals that led us to do the clinical trials to stop dual antiplatelet therapy at 4 weeks. And it was shown to be safe. So in these high bleeding risk patients, these modern stents are safe to stop dual antiplatelet therapy at 4 weeks. So if they're safe in high bleeding risk patients, if you have to, you could stop it in non-high bleeding risk patients at 4 weeks, but the recommendation is for 6 months in majority of patients. You're now able to assess high bleeding risk with a degree of personalization, i.e. with the patient there in front of you using the ARC-HBR app. There are other risk scores. We've heard about them in the course of this meeting, Precise Stat, Crusade, but the ARC-HBR app is a simple score that gives you a score for your patient there and then. The recent changes in P2Y12 guidance has been based on these trials of showing safety of the modern stents of stopping at 4 weeks of DAPT, and based on trials of high bleeding risk patients. So you base your P2Y12 guidance duration based on high bleeding risk. And the adjustments to duration are also based on assessment of bleeding risk. And the reason for that, of course, is that we know there are numerous studies that show that bleeding risk is associated with mortality, significant mortality. And the single major cause of bleeding, the site of bleeding, is the gastrointestinal tract. And this is why the guidelines have evolved to try and minimize bleeding risk in our patients. Thank you for your attention.